something that is really stunning when you think of the numbers of 70 million people totally having been infected with HIV, 36 million deaths thus far, over 35 million people living with HIV. And for those who say that we've actually taken care of this problem, look at the numbers in the last two bullets, with 1.6 million deaths in 2012 and 2.3 million new infections. This is a disparate pandemic, although it really involves everyone throughout the world. It is certainly disproportionately affecting sub-Saharan Africa, as you see on this horizontal bar graph on this slide. As Susan mentioned, in the United States, the problem also is most extraordinary, with 1.1 million people living with HIV, over 600,000 deaths, approximately, and this is the part that is really most painful for me, after so many years talking about this, is that there are 50,000 new infections each year, and it's been that way for almost 2 decades now. It hasn't gone below that, and that is most extraordinary. We have, again, a disparate distribution with disproportionately African American, disproportionately men who have sex with men in this country, and disproportionately young people who are infected. Now, having said that as the background, over the last 30 plus years, there has been an extraordinary investment in biomedical research and public health, which, although not yet at the end game, has been extraordinarily successful. And if one looks at this slide, these are a number of the breathtaking advances that we've seen in all of these areas. Perhaps the most impressive of which is in the arena of treatment. And in fact, I recall, and I tell the story often, when I first began taking care of HIV-infected individuals just about 5 miles north of here at our NIH Clinical Center, and I began in the fall of 1981, when a patient came into my clinic. It wasn't a clinic, it was a hospital bed, because everybody who came in was an inpatient at the time, because we didn't know they were sick until they were deathly ill. The median survival was 6 to 8 months, which means that 50% of your patients would be dead in 6 to 8 months. The transformation with the drugs that we now have available, which began in 1987 with the approval of AZT and culminated in 1996 and 1997 with the triple combination, has totally transformed that. So in that same hospital room or clinic, when I bring somebody in now, the way we do just this past week, if it's a young person who was relatively recently infected, in their 20s, and we put them on triple combination, we can project to them, look them straight in the eye and say, if they take their medication, we can project that they will live an additional 50 years, as shown on this slide from data from the United States and Canada. But we're seeing the same thing. We're seeing it not only here in the United States, Paul Farmer is seeing it in Rwanda, we're seeing it in Haiti, and Michelle Sadebi, who you hear from, is seeing in Africa and the rest of the world. So it's something that is, in fact, doable. Now, we talked about implementation. There is discovery and there's implementation. The implementation through the PEPFAR program, the Global Fund, the World Bank, the philanthropies, and most importantly, most recently, host countries taking the own responsibility for their problem, has led to extraordinary turnaround, such that now there are about 10 million people who are receiving antiretrovirals. And if you do again the projections, the actuarial projections, that translates into about 4+ million lives that have been saved over the last 10 years. So getting back to the global UNAIDS report, as I showed you, this has led to a decrease of about 30% in deaths over the last several years. We could say the same about prevention. I could talk my entire allotted 20+ minutes just on prevention. They're listed on this slide. Bottom line message is that prevention is not unidimensional. It's a combination phenomenon of which you can do different things for different groups depending upon the circumstances. But the bottom line is that it works. And if you look at some of the prevention modalities, taking PEPFAR's prevention of mother-to-child transmission alone has actually resulted in now about 1 million babies born HIV-free. We have pre-exposure prophylaxis. The results are variable. Many people in this room know that the original study showed about a 40% efficacy in men who have sex with men, more in heterosexual couples. However, when you look at the data of those who've actually taken the medication, the efficacy and hopefully the effectiveness in the community of these programs of pre-exposure prophylaxis is over 95%. And the issue that we have to address is the issue of adherence. And that's the reason why we're doing studies now with the use of long-acting antiretroviral drugs, as shown on this recent publication from Science that has a great deal of promise. In addition, we have treatment as prevention, which we know works. I could show you 10 papers on 10 slides that it does work. It works everywhere that it's implemented. If you treat somebody and bring their viral load to below detectable level, the chances are vanishingly small, not impossible, but vanishingly small, that they will infect someone else. So let's move on now then to what the results of those prevention are. Again, more than a 30% decrease in the infection transmission over a period of now more than 10 years. Now that's all great news, but we must remember, and I say this time and again, that it is far too soon for a victory lap, because we have a long way to go, not only in implementation, but also in new discoveries. Let's take a look first at implementation. Let's stay right here in this country, and it applies throughout the world. We have a very difficult problem. We have the resources, we have the capability. I showed you the previous slide of 1.1 million people in the country who are infected with HIV. About 16 to 18% of them don't know they're infected. Let me tell you an interesting statistic. 50% of the new infections in this country come from someone who does not know that they are infected. So imagine a perfect world. If you can access those individuals, those 16 to 18% who don't know they're infected, and put them on treatment, you can automatically decrease by 50% the number of new infections in this country. And then the care continuum. If you look down that reverse pyramid, you have 60+% who are in care, less who remain in care, less who are on therapy, and at the end of the day, only 25% in the United States of America, only 25% have a viral load to the point that would not only save their lives, but prevent them from infecting other individuals. So now, what about implementation of mother-to-child transmission? It's a tremendous victory, yet in 2012, there were still 260,000 infants globally who acquired HIV infection. What about circumcision? Circumcision really works. The initial studies from South Africa, Kenya, and Uganda showed about a 55% effectiveness, efficacy in blocking acquisition in people who were circumcised. It's really interesting when you're in science. Usually results get worse as the time goes on. The results with circumcision get better. If you follow up in Uganda, it's about 75% effective now for people who are circumcised. Yet, we are far below the goal of UNAIDS and other organizations of circumcising individuals. We have only 20% of individuals in one study were willing to be circumcised. That tells us that we have a long way to go in that interdigitation between biomedical interventions and behavior. We cannot forget behavior when you're talking about an intervention that works. So let's briefly go on to discovery. There are a lot of things that we need to discover, but two of the holy grails are a cure and a vaccine. So let's take a quick look at the issue of a cure. There's a lot of confusion about a cure. I'm going to try and make it really simple, really briefly. You tend to think of it in two major buckets: viral eradication, or not eradicating the virus, but being able to get somebody off therapy and still not have them relapse. Let's take a look first at viral eradication. In viral eradication, that means get rid of the virus completely. That is not going to be easy. But one thing we do know, and it was an interesting, iconic experiment, actually a healthcare phenomenon that was done that told us an important principle. The earlier you treat, the better chance you have. And that was really manifested in what we now know, the famous Mississippi baby, who was treated within 30 hours of infection, and by circumstances, after months of therapy was stopped, and there's no sign of virus in the baby, now 3 years later. Based on that, the NIH has begun a study in which we're going to take a look at babies who were born of mothers who had not had prenatal care, who were essentially at a very high risk, and we're going to treat them immediately as if they were infected, as opposed to waiting to see if they're infected and then giving them treatment, and find out if that N=1 with the Mississippi baby can be translated into N=thousands. Let's move on now to the other issue that's of importance, and that is the issue of something more draconian. We all know about the Berlin patient who was transplanted with a stem cell transplant of a Delta 32, which means, for those not familiar, that the virus cannot infect the cells. That person is so-called cured of HIV, but that's not practical for the broader number of individuals. It was tried in people, 2 patients in Boston, who didn't have a Delta 32, who were the donors of the stem cell. And as we know from the newspaper articles and recent presentations, both of those patients have relapsed, which has led to a very sophisticated group of studies of trying to do gene therapy in vitro and essentially edit cells to block out the CCR5 receptor, grow them up, and then retransfuse them back into an individual. This is interesting work that has now shown some promise, as shown in this New England Journal of Medicine paper. But from a real practical standpoint, the post-treatment viral controllers is the way we think it will go. And that is, there are many examples. One example from a French cohort called Visconti, in which they were treated very early, a large number of individuals, and then a certain subgroup, when viral was suppressed below detectable level, and the antiretrovirals were discontinued, it turned out that a certain proportion of them, well above the percentage you'd expect to be an elite controller, did not rebound. My bottom line message to you is that when you think about a cure, think about the care continuum and getting people on therapy as early as you possibly can. Because if a cure is a home run, that's first base, and that's where you've got to be. So, let's now talk a little bit about cures. We all know President Obama has pledged $100 million to find an HIV/AIDS cure. And the one thing that we know is that although we can't guarantee it's going to happen, we are certainly going to try. But in a realistic way, it really has to be simple, safe, and scalable. Because you don't want something to be worse than the actual procedure that you're doing. So if someone can get along well on 1 pill a day, you don't want to do something really harmful to them to get them off that pill. Let's make sure we don't forget that. And then finally, there's the challenge of a vaccine. We did the first vaccine trial at the NIH in 1987, and it was at a time of enthusiasm and naivete. The naivete was understandable. We thought like any other microbe, you give an envelope and you inject it and you make a neutralizing antibody. Then we found out the body doesn't like to make neutralizing antibody against HIV. In fact, infected individuals have a hard time doing that. And as the years went by, with a combination of planning and empiricism, one trial actually worked, not enough for prime time, but enough to tell us some very important things. And that was the RV144 trial that took place in Thailand with 31% efficacy. The amount of information shown just by a few slides, a few papers on this slide, have been extraordinary, telling us things we wouldn't have predicted. That an antibody against a region that's a variable region that you wouldn't think would be protective turns out to be protective. But the direction of the field, now and in the future, is focused on having been able to take what happens rarely in vivo and to make it happen more often. And that is, we've identified the epitopes on the envelope that are the binders of the neutralizing antibodies. And the challenge we face now is to take those, they're referred to as neutralizing epitopes, those little circles on the envelope. How do you make them into what we call an immunogen? Namely, that when you inject it into an individual, that person will make the broadly neutralizing antibody that is A, so rare in HIV natural infection, and B, takes a few years to occur. So listen to the challenge. Tom Arkin mentioned that he's been asking me that question every year for the last 29 years. It is that we need to do better than natural infection. Most vaccinologists say do as good as natural infection and you got a vaccine. We need to do better. And when we do that, I believe the combination of treatment, non-vaccine prevention modalities, and shown on this slide when you do mathematical models, we're already on a downslope, but it isn't acute enough. We want it to go down to that blue line where it really starts to get acute. But we believe strongly that the only way that you're going to have a durable end of the AIDS pandemic is a combination of all of the above. Treatment, non-vaccine prevention, and vaccine prevention. And then and only then do I think we'll begin to see and have a durable situation of an AIDS-free generation.